All right, we're almost through our last psych exam, guys. Let's get excited. Here we go. Well, you already know how I feel about this one. Let's keep it moving. And we're gonna go ahead and start on dissociative disorders. All right, and to begin with some quick definitions. Whoops, did I say quick? My bad. I meant to say to begin with some definitions. We're gonna start with dissociative disorder, which is defined as a disruption or discontinuity in any of your basic psychological functions, whether it be from consciousness to memory to the way you perceive things or to how you act or behave. To continue with some key terms, we have dissociation, which is a unconscious defense mechanism that involves segregation or separation of any portions of your mental or behavioral process. So basically they're just split in the middle, just like the movie Split. His mental process was split. Another example is Mr. Robot, mental process split. That's dissociation. Now depersonalization is when an individual feels detached from themselves. So depersonalization, deperson, so you're detaching from yourself. A similar association can be used with derealization, de-reality. So you're separating yourself from the reality, specifically meaning your environment. And then lastly, we have dissociative amnesia, which we all know what amnesia means. All you have to know further is that it could be either partial or complete amnesia. So I don't know about you guys, but I missed this question on the quiz. So I'm assuming they're going to bring it back for the test. So I created a mnemonic to help you remember it. Choose to use it if you would like. My mnemonic is Dad is altered and confused. Also, if you can't read, we're referring to the 5 core components of dissociative disorders. So my mnemonic is going to be Dad is altered and confused. So DAD is going to be depersonalization, amnesia, and derealization, so DAD, and then is altered, is confused, or is altered and confused is going to be I for identity alteration is the is altered, and then the is confused is identity confusion. It helped me remember it. Hopefully it's also beneficial to you guys. And this slide is just summarizing the 5 types of dissociative disorders. And as you guys know, we're going to go ahead and get through each one here. Alright, so before we start with dissociative identity disorder, I have some pre-section questions. So what are the 5 core components of dissociative disorder? What are the 5 core components of dissociative disorder? Let's see if my mnemonic was helpful or not. Number 2, 2 methods of inducing dissociative identity disorder. What are 2 methods of inducing dissociative identity disorder? And this is if you're the provider trying to induce it to the patient. Number 3, describe the integration phase of dissociative identity disorder treatment. Another quiz question that I missed, so I want to make sure we got this before the test. So describe the integration phase of dissociative identity disorder treatment. And then lastly, what's the most common risk factor of dissociative identity disorder? So dissociative identity disorder, this is what I consider the split disorder, so like the movie Split, or if you're a TV guy, it could be the Mr. Robot disorder. But you guys get the idea. They have 2 or more personalities. They may forget parts in their lives. Specifically, this I think of Mr. Robot. It helps me a lot with this one. And then obviously, if you're forgetting parts of your lives, you're going to have distress or impairment in ADLs. And if you didn't, it wouldn't be a psychiatric disorder. Probably the most important thing, other than those 2 on this slide, is the association between this disorder and suicide. So over 70% attempt suicide. So I feel like it's a high number. Maybe we'll be expected to know that. Here's another useless chart or table. Feel free to look at it. I'm skipping it. So basically, the only thing I take from this slide is no one knew about this disease until a movie and a book came out. Useless fact, so it means it's probably going to be a question. The book and movie was called Sybil, whatever. Who cares? So, also, probably important, the comorbidities associated with this condition include anxiety. So if you're anxious, probably going to become depressed. And if you're depressed, you're probably going to do drugs. And if you do drugs, you probably do weird shit. So I consider that as the pseudo seizure, which is now called a non-epileptic seizure. So it's basically just fake seizures that these people will do because they have psychiatric issues. And then lastly, if you remember before, the high suicide rate. So once they get down to this portion and the disease, they commit suicide. That's just how I remember it. Let's see if it works. So I'm not entirely sure what the slide is saying, but I think the big take-home point here is that these quote-unquote symptoms that it's referring to can be caused by either role-playing and or hypnosis. The thing I'm not really sure is whether it's referring to these symptoms as true dissociative disorder or if this is like a pseudo dissociative disorder. Either way, I just think it's important to know that role-playing and hypnosis can lead to DID symptoms of some sort. So risk factors for DID, I think it's pretty similar to any other psychiatric illness. Bad things in childhood leads to psychiatric illness. Of note, though, is that there is a high association, so 90%, which is pretty high, of risk in DID is associated with child abuse and or neglect. And this is across many different countries, so not just the US. So the symptoms of dissociative disorder, or the presentation, however you want to look at it, varies based on males and females. So females, I say ladies are mad dramatic, so they have flashbacks, amnesia, they have that hallucinations, or they'll self-mutilate, so they're mad dramatic. However, the males, every lady says men have anger issues, right? So men are more likely to have criminal or violent behaviors triggered by prison or combat. More men in prison, more men in combat. I don't know about the prison stat, but whatever works for me. We all know there's going to be a differential diagnosis question because we all know who's writing the test. So basically, any other psych issue can be in the differential, plus seizures, as we talked about before, these non-epileptic seizures as they're called, or pseudo seizures can also be in the differential because you have to make sure they're actually not having real seizures. So this is another one that got me on the quiz, so I want to make sure we drill it home here. So treatment for DID, you start with phase 1. Phase 1, I think of safety plus your ABCs. So you have to make sure you're safe, then you treat the patient. So you stabilize them. And how do you stabilize patients? You go through their ABCs. Now phase 2, you have to bring the personalities together, kind of make them have a handshake. So the way I think about this is you're going through marriage counseling. So your two personalities is the wife and the husband. They have to seek counseling, so they're confronting their issues. They're going to work through it, and they're going to try to come together and integrate into a single marriage. If it succeeds, then you move on to phase 3. But if you're kind of arguing in the counselor's office and you're about to fight each other, then guess what? You have to go backwards for safety. So that's how I think of the treatment for this. So then once you do finally meet to phase 3, you reach the integration and rehab phase, which also has 3 more phases. Now for phase 3, for me, I'd seen the show Mr. Robots. If you've seen that, that's the reference I'm going to use. So for the cooperation and agreement phase, this is when he's aware that there's 2 personalities, and then he kind of works together with him. So they still know they're there, however they are functioning as a cohesive unit, so they're cooperating together, and that's an arrangement between the 2. Then you have partial integration. Now for partial integration, there's still two distinct identities, if you will. However, they start to kind of become one. They're still there, but they're kind of just, I think of the two personalities as one person on top of another man's shoulders, and they're just kind of walking together. One's just sitting on top of their shoulders. They're working as one, but they're still two cohesive units. And then lastly, you have the final fusion, where basically you have complete integration, both become one. And then they say that this doesn't happen often. I can imagine it doesn't happen often at all. However, it's still the ultimate goal for these patients. So now the answers to our previous questions. What are the 5 core components of dissociative disorder? What are the 5 core components of dissociative disorder? If you remember my mnemonic, DAD is altered and confused. So depersonalization, amnesia, derealization, is altered is identity alteration, is confused is identity confusion. Next question. 2 methods of inducing DID. 2 methods of inducing DID, and that was hypnosis and role-playing. Next, describe the integration phase of DID treatment. This was discussed in the previous slide. If you need to remember, go ahead and rewind a little bit. And then lastly, what's the most common risk factor for DID? As you saw before, 90% associated with child abuse. And this is through multiple countries. All right, for some more questions, describe dissociative fugue. Describe dissociative fugue. And describe the difference between dissociative amnesia and permanent amnesia. Describe the difference between dissociative amnesia and permanent amnesia. So there was a huge definition of dissociative amnesia. It's basically summed up as this. You have amnesia, plus you have an effect on your ADLs, you have dissociative amnesia disorder. And obviously it can't be caused by things like substance abuse or other medical conditions, because then it wouldn't be psychiatric in nature. And then there's 2 subtypes of dissociative amnesia. There's localized, which is towards a specific event. So you forgot you went to the mall, or you forget a specific traumatic event. Or there's general amnesia, where you lose track of who you are, or you could lose big periods in time. And these individuals may also be unaware that they even have amnesia, so they have amnesia towards their amnesia. This is going to be common in general amnesia. And there's also a term called dissociative fugue, which, if you remember from the quiz, it is you basically change locations, so geographic location, and then you will lose who you are, or you'll be unable to recall things that you have done in the past. And although it's mentioned in this section, just note that this is rare in dissociative amnesia and is more common in dissociative identity disorder, which begs the question why it's mentioned in this section at all, but I'll regress. And then obviously you have to rule out other causes of dissociative amnesia because duh. It's also important to note that dissociative amnesia differs from permanent amnesia in that dissociative amnesia is a psychological condition. Thus, it is reversible because the initial information and memories were actually stored successfully in your brain. However, to contrast with permanent amnesia, which is irreversible, that is due to a neurological event. So damage or toxicity to the brain cells at some point damages the ability of your body to store that information. Thus, you are unable to retrieve it in a future time period. This condition can affect people of all ages, from children through adulthood. It often presents as a sudden onset with variable duration. It can last anywhere from minutes to decades. And these individuals can experience these episodes multiple times throughout their lifetime. Additionally, these people may not even realize that they lost information until many years down the road. Now the answers to before. Describe dissociative fugue. It's an abrupt change in geographic location, plus the loss of identity or inability to recall the past. Next, describe the difference between dissociative amnesia and permanent amnesia. Remember, dissociative is psychological in nature, thus it is temporary, whereas permanent amnesia is due to a neurological insult, thus it is not reversible because the information was never correctly stored in the first place. So we talked about these two terms briefly before, but to review, depersonalization is separation from your own person. So you have detachment from your mind, self, or body, and describe it as living in a dream. So you're looking at yourself from the third person perspective. Whereas derealization is detachment from your reality or your surroundings or your environment. Kind of the same terms, however you like to think about it. And then to have this disorder, you must have one of those two terms along with impairment in ADLs. This is just like every other psychiatric condition, needs to affect your ADLs to be considered a disorder. And it also states here that their reality testing remains intact, which I don't know how that makes sense for derealization disorder to have intact reality testing, but that's what it says, so go with it. So when a patient presents with dissociative symptoms but doesn't meet the full criteria for either DID or dissociative amnesia, you can categorize them as an other specified dissociative disorder. So you categorize them as that, and then you give a specific reason. And these reasons are described here. Now note that an acute dissociative reaction to a stressful event must occur for less than 1 month in total duration. And then also another descripting term that they use here is dissociative trance. And this is where the patient enters a trance. So when you're in a trance, all you're doing is focusing on a single object and you lose kind of your surroundings. So that's basically what it's saying. They're just focused in on one thing. And then they may also present along with stereotyped behavior, such as finger movements. The cause of these disorders is kind of up for debate. There is some people who think it is caused by trauma, specifically child abuse, but there's no real good evidence. There's also some research that thinks that these conditions can be caused by a fragmented sleep-wake cycle. So thus, when they lose sleep, symptoms increase, and when they gain sleep, you have a decrease in dissociative symptoms. There's also social factors such as iatrogenesis, and this is where basically the therapist will cause these symptoms due to their expectations. Treatment of dissociative disorder uses a lot of the same tools as before, so CBT, DBT, medications such as SSRIs, for example. Now, two new therapies that are mentioned here are abreaction and eye movement desensitization and reprocessing. Now, abreaction is the expression of a previously repressed emotion, and this is achieved by reliving the event. So for example, if I experienced an event in the past that would normally make me cry, but I held it in, then abreaction will result in me crying after reliving the event. Now this can occur through hypnosis or suggestion, which is basically the same thing as hypnosis. And then the second one here, eye movement desensitization, we'll talk about here shortly. Now if you remember, CBT kind of works like a circle. Its belief is that the thoughts can affect an individual's emotions, and those emotions will affect that individual's behavior. And these can kind of go in circles, so behavior can affect thoughts. So the way this is used in dissociative disorders is that clinicians will focus on addressing these obsessive thoughts that are causing these derealization problems. And by doing this, they will try to manipulate those thoughts through a change in behavior. So they're kind of going in reverse. So now the behavior is affecting the thoughts, which will ultimately improve those emotions. The next therapy used is DBT. Now DBT is what I like to call a hippie version of CBT. So it has the same general concept of CBT, however it also utilizes specific techniques such as meditation, breathing exercises, all things you could picture me doing on a regular weekend, right? So they do this to try to decrease the dissociative related symptoms. Next up, we have psychodynamic psychotherapy. And the main concept here is that many of these conditions are due to negative events during an individual's childhood. So the focus is to address these negative childhood events, and then by addressing those events, hopefully you can reverse some of the negative effects that has had on this patient through adulthood, and hopefully it'll improve their behavior. Lastly, we have eye movement desensitization and reprocessing. Now this one seems a little weird, but bear with me. So what they do is that the practitioner will be moving their finger from side to side in front of the patient. And during this period, they will be revisiting difficult memories in that patient's past. And ultimately, they're trying to reprogram that memory so that it doesn't affect the patient any longer. So I figured since you guys always call me the next Dr. Wood, I'd give you guys a pharm quiz. So here we go. You guys ready? Number 1, list 3 side effects of aripiprazole. List 3 side effects of aripiprazole. Number 2, what medication can be used in conjunction with an SSRI in order to treat dissociative disorder? What medication can be used in conjunction with an SSRI in order to treat dissociative disorder? Lastly, what medication class is contraindicated in dissociative disorders? What medication class is contraindicated in dissociative disorders? Now to get into medications, basically when in doubt, pick an SSRI for the treatment of any psychiatric illness. Period. So learn to identify them, and if you have no idea, just guess SSRI and you'll probably be correct. Now, if it asks for a medication that can be used in conjunction with an SSRI for the treatment of dissociative disorder, that's when you're going to want to use lamotrigine. Now, if you remember from before, lamotrigine is an anticonvulsant. Just note that lamotrigine also is associated with Stevens-Johnson syndrome. I don't remember if it's actually mentioned in this slide, but fun fact otherwise. So you may be sitting there wondering why an SSRI, which is categorized as an antidepressant, is used successfully in the treatment of dissociative disorders. Well, the reason is that dissociative disorders is closely related to anxiety disorders. And if you remember, SSRIs are often used in anxiety disorders. So by treating the anxiety disorders, that may have an associative benefit in dissociation disorder treatment. Also important to note that benzodiazepines, which are often used in anxiety medications, are contraindicated in dissociative disorders. And this is due to a potential to exacerbate dissociation. Your guess is as good as mine as to why, but it is important to know that. Another medication class that can be used is atypical antipsychotics. These medications have been found capable of stabilizing mood and reducing anxiety in people with dissociative disorders. However, it's important to note that these individuals are not, in fact, psychotic or are not undergoing psychosis. In fact, one of the most important diagnostic criteria is that these individuals have intact sense of reality. So they are aware that their perceptions are unusual. However, this would not be the case in a true psychosis. So it's also important to note the typical side effects associated with an atypical antipsychotic. So I use the mnemonic extra fat heart. So you have extra pyramidal side effects. So these are the movement disorders, the dyskinesias or the akathisia that were mentioned in pharmacology. And then it's extra fat heart, so you have weight gain. When you have weight gain, you have diabetes, and most people with diabetes will also have hyperlipidemia. And once you have too much cholesterol, that can lead to cataracts. And then once you have all these other comorbidities, you're bound to have atherosclerosis, which will lead to sexual side effects. So that's just kind of how I connect the dots as far as the extra fat. Now you have the extra fat heart, you have QT prolongation and myocarditis. Hopefully that's beneficial. All right, now for the answers of our pharm quiz. By the way, I don't want to hear any arguments later. Yes, I'm talking to you, front row. No arguments later about these answers, all right? So, number 1, what were the 3 side effects of Riprazole? This is used the mnemonic extra fat heart. You can read these at your leisure. Number 2, what medication can be used in conjunction with an SSRI in order to treat dissociative disorder? That's going to be lamotrigine. And then lastly, what medication class is contraindicated in dissociative disorders? And that's benzodiazepines. All right, we're at the home stretch. Let's finish it off strong. So to overview what this is saying, basically psychiatric conditions such as depression can affect the body. And this is displayed by the association between depression and coronary artery disease. So a somatic symptom is basically when the patient has a physical complaint, but there is no underlying medical cause for that complaint. Although there's nothing specifically wrong with the body, the mind is interpreting it as a true problem. Now there are 5 total somatic disorders, and we'll be covering each here shortly. So the first one we're going to talk about is somatic symptom disorder. Now, to be diagnosed with this condition, you must have 1 or more somatic complaints, and they must be ongoing for at least 6 months in duration. And additionally, this condition is more frequent in those of lower socioeconomic standards. So next one is going to be illness anxiety disorder. And this is when you have anxiety over an illness. So basically these patients have a minor symptom and they perceive this minor symptom as a life-altering physical illness. And of course, you must have these feelings for at least 6 months in duration. It's also important to note that this is not referring to anxiety over a true serious illness. This is only referring to a minor or missing physical symptom. Now, conversion disorder is when a mental conflict is converted into a somatic sign, specifically referring to a neurological related sign. So this is different than somatoform disorder, and that this refers to specifically neurological symptoms. So numbness, seizures, blindness, paralysis. These are all neurological symptoms caused by a mental conflict. Now the next 2 disorders are very closely related. You have malingering and you have factitious disorder. Malingering is when a person will make up an illness in order to achieve an external gain. So I think of this as the homeless person who just got kicked out of the shelter, and they call 911 because their toe hurts. Their toe may not actually hurt, however, they are faking this illness in order to achieve an external gain, such as getting a bed in the hospital, getting a blanket, etc. Whereas factitious disorder is similar to malingering in that the condition is made up. However, it's different in that the patient just wants to assume the sick role rather than an external gain. To clarify what I was saying before, in factitious disorder, they are trying to assume the role of the patient for the goal of gaining attention, sympathy, or reassurance. This is in contrast to malingering, where their ultimate goal is external incentives, like the example of the blanket or food, so forth. And these diagrams, if you choose to use them, seem okay. So I want to take some time to describe this slide because I find it kind of important. So in somatoform disorder, they are subconsciously creating a fake illness. So they're not aware that they're creating this illness, but there is no true motivation for said illness. This is strictly a psychological condition where they cannot have any control over the matter. Whereas factitious and malingering, there is some consciousness to this disorder. So in malingering, there is both a conscious mechanism to the injury, so the person, mostly caused by the external factor. So let's say the person wants a hot bed and sleep at night. So they know that by faking an illness, they can go to the hospital and receive that hot, warm bed at night. So they're consciously creating a fake illness for a conscious effort towards an external goal. Whereas, although factitious disorders, they are consciously making up an illness, they're subconsciously doing it for the extra attention, although they're not aware of it at the time. Hopefully that makes sense to you. So for the last few slides, I keep bringing up the homeless factor, like with the malingering and the guy who got kicked out of the shelter. Well, the reason is because this is the most common presentation occurs in those of low socioeconomic standing. Additionally, it's most common in minorities, specifically African Americans and women. The cause of most of these somatoform disorders is mostly unknown. However, several psychological factors can be considered, such as traumatic stress, a primary gain, such as an external gain in the case of malingering. There's also some cognitive tendencies, such as amplification or exaggeration, and alexithymia, which is an inability to express emotions. However, at the end of the day, this is a diagnosis made by exclusion. So this is a busy slide, but basically, to treat somatoform disorder, you're going to address lifestyle modifications, you're going to include the family if possible, and you're also going to treat any comorbid psychiatric conditions as indicated. Well, that's it. Hopefully it was helpful. Don't forget to go psychotic on that like button. Also, don't forget to subscribe. All right, see you guys later.